Adrenal insufficiency in cardiac surgery patients. Pathophysiology of the adrenal gland. The CRH production is produced by the hypothalamus. CRH stimulates the pituitary gland to produce ACTH, and ACTH stimulates the adrenal gland to produce cortisol. Cortisol exerts a negative feedback on production of CRH and cortisol. Zona glomerulosa produces mineralocorticoid, zona fasciculata produces stress cortisol and androgens, and zona reticularis produces basal cortisol androgens. Glucocorticoids 90% are bound to corticosteroid binding globulin and albumin to lesser extent. 10% is free. Cortisol is pathophysiologically active. Half-life is 70 to 120 minutes. Cortisol is not stored in adrenal gland. Glucocorticoids bind to intracellular receptors and then moves into the nucleus, affecting the transcription of various genes. Metabolic role is it stimulates gluconeogenesis, decrease glucose utilization, decrease protein synthesis, and increases catabolism. Increases lipolysis and oxidation of fatty acids. Cardiovascular, it increases the blood pressure, increases the sensitivity of vasculature to catecholamines and angiotensin. It has anti-inflammatory effect, reduces the circulating T and B lymphocytes, eosinophils, monocytes, and neutrophils at the site of inflammation, decreased production of cytokines and chemokines, increased production of macrophage migratory inhibitory factor, and increased red cell production. Adrenal insufficiency. It could be divided into primary, secondary, and tertiary. Primary adrenal insufficiency could be congenital or acquired. Congenital is due to congenital adrenal hyperplasia, and familial glucocorticoid deficiency, adrenocortical deficiency, aldosterone deficiency. Acquired could be autoimmune, infectious disease, infiltrative processes, and drugs. Secondary adrenal insufficiency, it could be isolated panhypopituitarism associated with structural defects, as for example supraoptic dysplasia. Acquired could be lymphocytic hypophysitis, neoplasm, and exogenous steroid. Normal HPA response to stress. Multiple changes occur to maintain the hemostasis during the stress. Activation of sympathetic adrenal system leading to secretions of epinephrine and norepinephrine. Activation of HPA axis lead to release of CRH and ACTH and eventually cortisol. Corticosteroid binding protein levels fall as low as 50%, leading to increase in free cortisol. Increased translocation of GR complexes into the nucleus results in alteration of systemic inflammation response and cardiovascular function. It could lead to inadequate cellular corticosteroid activity for severity of the patient illness. Dynamic process. The patient may not have it on admission but may develop it later. The pathophysiology is poorly understood, and structural damage to the adrenal gland due to hemorrhage or infarction may lead to a long-term adrenal insufficiency. Most critically, it'll develop reversible HPA axis dysfunction and decreased production of the CRH, ACTH, or cortisol. Decrease and alteration of the glucocorticoid receptor, decrease in the nuclear translocation of the glucocorticoid receptor complex, and due to endotoxin and pro-inflammatory cytokines. Failure to activate GRs to downregulate the production of inflammatory mediators, systemic inflammation associated with GS resistance, glucocorticoid resistance. Non-survivor of sepsis may have random cortisol level of more than 20. Others found that Non-survivors have a lower non-random cortisol level compared to survivors, and lower level of the cortisol and higher ACTH is associated with severe disease and poor outcome. The shock poorly responding to fluid and vasopressors, especially in the septic shock, catecholamine-dependent shock and prolonged mechanical ventilation and sudden deterioration of seriously ill patient with DIC, traumatic shock, severe burns and sepsis may be due to adrenal hemorrhage or infarction. Diagnosis of adrenal insufficiency. Currently based on random cortisol levels and a delta cortisol after the high dose of ACTH stimulation test. Free cortisol is more physiological importance, but normal level is acute illness and not established test, not widely available. Low dose ACTH stimulation tests thought to be more physiologic and sensitive, but limited data. Delta cortisol assesses the ability of adrenal cortex to produce cortisol but does not confirm the integrity of HPA axis. Above tests do not evaluate the resistance to end organ level. Treatment with glucocorticoids. The studies have shown that association between adrenal insufficiency and refractory shock. Some studies show favorable outcome with administration of glucocorticoid. In severe sepsis, there is a compromised endothelial integrity, systemic vasoplasia, and impaired cardiac contractility. Cortisol is thought to modulate a biochemical pathway associated with those processes. Adults with sepsis have a different dose response to norepinephrine compared to adults without sepsis. Marked improvement of dose response is seen after administration of glucocorticoids. Downregulation of pro-inflammatory factors. Attenuating immunity and delaying the wound healing. Hyperglycemia. Adult data raise concerns of increased risk of nosocomial infection, multiple organ dysfunction, possibly alteration of the brain development, as for example neurodevelopment, outcome in neonates treated with dexamethasone for BPD. Increased mortality and morbidity is associated with methylprednisolone administration in traumatic brain injury. Increased mortality of ARDS patients started on steroids after 14 days of illness, and higher rates of neuromuscular weakness. Dysfunction of the HPA axis is critical illness is best described by the term critical illness related corticosteroid insufficiency. The term absolute or relative adrenal insufficiency are best avoided in the critical care context. Diagnosis is by delta cortisol less than 9 mcg per dl after 250 mcg cosinotropin or random total cortisol of less than 10 mcg. The use of free cortisol can not then be recommended at that time. The ACTH stimulation test should not be used to identify those patients with septic shock or ARDS who should receive glucocorticoids. Hydrocortisone should be considered in the management strategy of the patient with septic shock, and particularly those who have responded poorly to the fluid and vasopressor agents. Moderate dose glucocorticoids should be considered in management of strategy of the patient with early severe ARDS and before day 14, and the patient with unresolved ARDS. The role of GC treatment is less severe and ARDS and ALI is less clear. In patients with septic shock, IV hydrocortisone should be given in dose of 200 mg day and 4 different doses of the bolus of 100 mg followed by continuous infusion and 10 mg per hour. The optimal duration of GC treatment in patients with septic shock and early ARDS is unclear. Patients with septic shock should be treated more than 7 days before tapering, and those with ARDS more than 14 days before tapering. GC treatment should be tapered slowly and not stopped abruptly. The treatment with fluorocortisone is considered optimal. Dexamethasone is not recommended for the treatment of septic shock or ARDS. HPA activation is necessary to help the adaptation of stress. There is evidence to support existence of adrenal insufficiency in critically ill patient. The clinical relevance of adrenal insufficiency in critically ill pediatric patient is not clear, and safety and efficacy of steroid use in critically ill children is not proven. Wide practice variability exists, and the risk of adverse effects such as hyperglycemia, nosocomial infection, and myopathy and neuropathy are unknown. Thank you.